So thank you to all three. Brilliant and very interesting topics. Thoroughly enjoyed that. Interesting. I think we live in interesting times. We've got with Siobhan in the middle between as it were, representing old school as to how things used to be done. People physically go around collecting things, extracting them from notes, and then the modernity of having NLP at some distance, extracting the data from it. As wonderful comparison of the two. Before we get into NLP, can I ask Siobhan a question that I know the answer to, but I think other people might be interested in? What happens to people when they turn up with, as their primary diagnosis, they turn up with suicide ideation? What's the next step? What's their care package like?
Well, based on the annual reports and that, they would say that approximately 82% of those who actually show up with ideation are referred on to psychological services. And even so, within that, at the time of presentation, approximately just under half of them receive psychosocial assessment in the emergency department. And then for those who don't get that, they are referred either the next day or longer term down the line to get psychiatric assessment.
Thank you. Just going to say to the wider audience, I've never seen such a shy and retiring group. If you could just set that chat alight with lots of your questions, that would be much appreciated. Natural language processing. Can you explain, Hamish and Charlotte, to me, someone who doesn't know an awful lot about how you would go around getting access to these data? Are there any particular problems about where you get access to them, and thinking in terms of the sensitivity and disclosure issues that might be around the sort of open text records that you will be analyzing in NLP? Hamish.
Well, I mean, I know that with Chris, there's the oversight committee that if you're kind of doing work that's got service user involvement and you'd need to get their sort of approval for studies.
So where is this data stored? I mean, there could be all sorts of things in there which are really quite sensitive, or talking about other family members and so on as well. So where do you store these data before you can run your algorithms, or are they just stored as generally as part of the electronic care record somewhere? Charlotte?
I mean, my understanding is they are all obviously de-identified, anonymized, and kind of routinely updated with any kind of possibility of names or anything kind of removed. So there's no chance that you could identify anybody. And then my understanding is when you're applying for kind of ethics for any of the studies, the sorts of topics that you're suggesting or keywords or anything that you're researching can't be too specific so that you'd be able to identify individual people. It has to be a relatively broad term so that there's no chance when you're searching through these keywords that any one individual would come up and it would be obvious who it was. That's my understanding of how they get around that.
Great, thank you. The other thing that occurs to me is that while there are very different approaches, both of these rely very heavily on what is written down in the clinical notes, as you said, Charlotte. And I mean, they're very quantitative, and yet the variability that is in what people write down in notes is quite impressive. And I wonder a couple of things. One, should we adjust for that in some way? These are clustered. Some people, what they write down will be determined by custom and habit, or by the form and the layout of the form, which might vary by provider. So should we adjust for that clinically or statistically? And the second question is, if we think things like suicide ideation or suicidal thoughts are important, should we be feeding back to the providers and asking them to collect that in a routine way and make it easier for us to identify these on the clinical records?
Well, I suppose one of the things about sort of suicidal ideation is that it is something that we all would routinely ask for. So I suppose it's one of, in terms of errors of relying on what the clinician's reporting and asking, it's probably one of the least topics that you'd worry about. I suppose some of the more kind of niche, as it were, symptoms that you might not ask or screen for with every patient would be more of a problem. But and then that would be something you might need to think about. But I think with suicidal ideation, it would be something that at least once with most patients, you probably would at some point ask for. But I suppose in terms of relying on what's being reported, it's a little bit similar generally, I suppose, to psychiatry, where you have to rely on what someone's willing to tell you. So it is difficult to sort of, for it all to be completely quantifiable in that sense, because you might ask if someone's suicidal, but they might not tell you anyway, in which case you've marked them as non-suicidal, but actually they are suicidal. So there's always going to be that problem regardless.
Yes, I wonder if everybody gets asked in the same way, at the same frequency, or do we tend to ask some people or with some diseases a little more frequently? And of course, then, are some people more willing to report or not, cultural and stigma and all that sort of stuff as well? Interesting to see maybe if there's variation in the predictive power by some of, in terms of ongoing suicide risk, etc. I can't think of any more questions, and the chat box is absolutely abuzz with apathy. So sorry about that. So what I can suggest here is that maybe we bring our break forward by a little bit. I think we've earned ourselves the gift of a little more extra time for tea and coffee. So I think we're scheduled for break at 5.
Sorry, Dermot, there's a question from
There is a
John?
question.
Yes.
Oh, yes, there is. Sorry, yes, there is, John. Sorry, John, thank you for this. Do you think this methodology be used for a dementia disease progression cohort?
So I think definitely it could be. I mean, we used the first dementia diagnosis as an index date because sometimes people have it, if they reattend, they get another kind of coding of dementia, but we use the first time they get a dementia diagnosis. I think this thing is, it would depend on how much they're attending mental health services, or if they're, for instance, sometimes post-diagnostic support is delivered by charities and things like that. So it may be that it's not capturing all of that information through Cliffe, where it's sort of routinely collected NHS mental health records. So they may be, for instance, seeing a GP or something. But yeah, I mean, potentially with linked data as well, you could do it that way. So I think so.
So with the very recent publication of the aducanumab trial, for all its controversy, I think there will be many farmers dusting off their amyloid treatment molecules, and we could anticipate treatments being available over the next few years. At that point, this methodology could be used to look at how fast people progress to different levels and even onto mortality. So I think it has a lot of potential.
Yes, I think, John, welcome. And yes, I think we're seeing the future here. I think in years to come, when we have these presentations, I think we'll be seeing an awful lot more and hearing an awful lot more about NLP and the richer data that we can get from this.
Yeah. So
sorry.
No, just thank you all. That's all.
So if I can just once again thank our 3 presenters for wonderful presentations and challenge us by bringing something that is entirely new and exciting to us. Thank you very much indeed. So enjoy some coffee, and if we could be back here for 3:20, that'll be great. Thank you.